Service Center webinar on combat COVID. You know that Medical Service Center is a socio-medical voluntary organization. We're working in almost 23 states all over India over the last 40 years. We are the medicos. We're working for the ailing, helpless people in disasters. It might be natural or it might be man-made. We are not NGO. We collect money from common people, our well-wishers. Our volunteers, maybe the professors in medical colleges or the medical students, nursing students, paramedics, or even village practitioners. They are doing their selfless duty. In the midst of COVID-19 pandemic, this is our moral responsibility to stand by the side of the common people and also the medicos for the frontliner and fighting against the COVID, taking their life at risk. We already lost more than 500 of doctors, many nurses, paramedics. Many of us, we have lost our friends, our father, our mother. Many have lost their wives, their husbands, their children. Within this last 1.5 years, the total world scenario, may be medical, social, economic, political, psychological, everything has been changed. In this grand national webinar, we have with us esteemed panelists. They are nationally and internationally reputed. We have with us Professor Dr. Sukumar Mukherjee, who is the former professor and head Department of Medicine, Medical College, Kolkata. He is our teacher, a legendary physician. We have with us Dr. Dhruva, Dr. Mradul Daga, the professor and head director of Department of Medicine, Maulana Azad Medical College, New Delhi. We have with us Dr. Kamalesh Sarkar, who is the director and scientist G, ICMR-National Institute of Occupational Health, Ahmedabad, India. We have with us Dr. Dhruva Chaudhry, who is coming soon, who is busy with some activity. Dr. Dhruva Chaudhry, professor and head Department of Pulmonary Medicine and Critical Care, PGIMS Rohtak, and the immediate past president of ICSSM. We have with us Dr. Kafeel Khan. He is also coming and joining. You know that he is a consultant pediatrician, fighter for the people's health, and twice suspended lecturer of the BRD Medical College, UP. And myself, Dr. Biplab Chandra from Medical Service Center. Today, our agenda, the number one is why this second wave is so fatal. Why this fatality or mortality rate is so high? Initially, it was told that the infectivity is higher than the first wave. But now we are seeing that no, the case fatality is also much higher than the first wave. The younger generation, without any comorbidities, they are affected. They are in a dying situation. Number two, the vaccination strategy. Where we are? Is there any definite planning? Why this dilemma regarding vaccination? And impending third wave, is it inevitable? Whether there is any scope to prevent this third wave, where we are suspecting, we are apprehending that the children will be affected much more in the third wave. So we are very sorry to say that every day in India, 4,000 people are dying in COVID-19 infection. Every day the cases are around 2 lakhs. All over the world, almost 35 lakhs people already died. It is the official data. I think that actual data is much more higher. The number is much more higher. In this scenario, surprisingly, we are seeing that our responsible central government, they have refused to exempt GST in COVID vaccination, mask, sanitizer, and even life-saving medical instruments like ventilators also. They have imposed 12% of the GST in ventilator. We did not restrict the international flights when the first wave just declined in the month of January end and February. Our different melas or political gathering in West Bengal particularly, and in some other states like UP, the COVID incidence increased. In this backdrop, amazingly, we are seeing that only the 4% of the population in India vaccinated with the 2 doses of vaccine. We are very... Good evening, sir. Good evening. Dr. Bibhuti Saha is with us. We are seeing Professor Sukumar Mukherjee, Professor Mradul Daga, and Dr. Kamalesh Sarkar, Dr. Professor Bibhuti Saha. I hope Professor Dhruva Chaudhry and Dr. Kafeel Khan will join soon. Our time is limited. That's why, first of all, I invite Dr. Daga. I know him very well. He's our teacher. Will give the answer and will guide us. I'll put some question to sir. So first of all, why the second wave is so fatal? Why the mortality rate is so high? Is our health system is ready to combat this second wave or impending third wave? What do you think about our health system? It may be primary healthcare system or secondary or tertiary. Sir, please.
Thank you very much for giving me this opportunity to be with stalwarts like Professor Sukumar Mukherjee, Professor Bibhuti Saha, and from Dr. Sarkar from NIOH. I think, yes, on the battlefront, we, in last 15 months, and my hospital being one of the first hospital converted into a COVID last year in March end in Delhi, had to create 1,500 beds for COVID. We knew that we are up to a difficult task. We knew that it's not an easy thing to be done. And we faced a lot of challenges during that first pandemic. And it started from, as always happens with government setups, you have some infrastructure problem, you have manpower shortage, you have shortage of paramedics, you have some kind of hesitancy. There are people who would not like to work. There would be, so all those kind of challenges we were able to streamline in next 3-4 weeks. Despite that, we had huge number because this is a government facility, and secondly, people who can't afford to go to private or from neighboring states, as always happens in Delhi, would keep on coming to our center. Having said that, we did okay. I think we had around 18,000 admissions during the first wave in our setup. We were able to discharge around 15,000. We were able to send back people to COVID care center, few, I think 1,000 or 1,500, and we lost quite a few during that wave. Initially, in initial 3 months, because we were not sure what to give, what not to give, what is the treatment. Besides a good intensive care, there wasn't any good treatment available. So we had a lot of those challenges, plus problems at all fronts. It happens with availability of all kind of things, from medicine to equipments to all those. Having said that, November, December were very good period for us. So also was Jan and February 2021. And we were doing in our college sero surveys for Delhi for almost 3 sero surveys we had done. And January 11th was the last sero survey, where a population of around 20,000 odd people from different zones were tested. And we found, to our surprise, more than 45% positivity in terms of antibodies. So in Delhi, with that high positivity, we thought that we are quite close to, you need 70% for herd immunity. We thought we are very close to it. So we were definitely taken aback by this sudden second surge. And I think the fault line was probably that 45% seropositivity did not really account into a lot of floating population which Delhi has. So you have around, I think, almost 3-4 lakh people visiting Delhi every day for their work from outside and neighboring states. And maybe some of them were not taken into account and that's why we probably thought that we are quite close to getting into herd immunity, but we probably missed out on that. And you rightly said that we started having those complete opening up of all facilities, which you cannot, keep closed for indefinitely, because you are done. Then you're going to lose people to hunger, to no job, to no food to eat. So we could not do that. But in doing that, the COVID appropriate behavior suffered a setback. Yes, people also become reluctant, and we could see people not wearing masks even if in public places. So the second wave came because of these couple of things, plus, of course, the focus of central government, primarily, to some extent state, was not there, and they thought that we have already won COVID. And that kind of a message which went from them to the public probably further added to this, that, yeah, COVID is now over. So second wave, one reason is, the major reason is that. The other reason, I think, is we are far behind in vaccination. We started very late, and we had initially that controversy about co-vaccine, because initial almost 4 to 6 weeks, it was administered under a trial condition. So everyone taking co-vaccine was to sign a consent and all that. And that kind of a thing, with the social media being so active, created a lot of confusion amongst people. And vaccine hesitancy is known all over the world. Even best of the countries, you find 15-20% people do not want to take vaccine at all. So slow vaccination, quite leniency, I would say inappropriate COVID behavior by public as well, and not strict measures being thought of when in March itself some indications started coming, 2021, late, I would say second or third week of March, that yes, the COVID is coming back, but government remained absolutely in a denial mode for 3-4 weeks, I would say. I think it was only in 7th, 8th of April that central government thought that yes, now we have COVID again, second wave, and huge number. So we had all those deficiencies, and unfortunately the elections in the states, the Kumbh Mela, probably that could have been avoided, those religious gatherings. So I think these are the reasons, I feel, Doctor.
Your discussion, we can tell that the complacency was one of the important factor, our complacency. That
absolutely.
After the first wave, we thought that everything has been over. No, there will be no second wave, there will be no third wave. Although, sir, it is true that the scientists and all the experts throughout the world, they clearly told that the second wave is impending.
Absolutely. Okay. Not only that, even the task force here, some of the members of the task force in the central government had written as early on 7th or 8th of March, I don't remember exact date, when they had written to the cabinet secretary that, sir, we should be preparing for, we may have a COVID surge anytime. we are very close to having a COVID surge again, and probably no action was done on that. So no, nothing was, you're just issuing one letter to all states that be prepared for it in end of March. That's too late, too little. So definitely there is. And of course, the people also became a little bit careless. But again, they would follow what the message comes from the leadership, from all that, when they thought that we have already won COVID and we are now helping and we are showing the world how have we won the COVID. So that was the scenario.
Thank you, sir. My next question to you, sir. Do you think any change of treatment strategy in second wave in comparison to the first wave?
Yeah, and then one more question you asked me about why young people are succumbing or the case fatality ratio.
Yeah, without any comorbidity.
Yeah, at the moment, I would not say that the case fatality ratio or case fatality ratio is very high from the previous wave. We are still to analyze those data. Yeah, instead of say 0.3% or 0.6 or 0.9 or 1.1%, it may be little more or so. But yes, this has been a big surprise this time. We have seen young patients, 30s, 40s, without any comorbidities. And few factors. One is the smart virus, the mutation and multiple mutation. Secondly, the spread this time has been much faster, infectious nature of the virus. And we have seen when family member one gets affected, last time we thought that if one family member of 5 is affected, maybe the other one gets affected and 2 still escape. This time the whole family would get affected very soon. And of course, we can never predict the course. Other thing we observed this time was a lot of patients had very high grade fever in this wave, going up to 103, 104, lasting for 6-7 days at a stretch rather than for a couple of days, and then the fever intensity going down. And suddenly, on the other hand, we had people who had very mild disease and suddenly on 8th, 9th, 10th day, suddenly become very sick. So we definitely had something to do with immunopathogenesis of this mutated virus, which attacked which produced very severe disease. And some of the some of the patients did not really anticipate that early. As far as one more factor which might have contributed to this worsening is this time, a lot of patients were put on oral steroids on day 1 or 2 of their symptoms. By a lot of medical professionals, I've seen at least 500 prescriptions across the country coming to me on WhatsApp, and people known to me or taking my opinion. A lot of people were put on not very high doses, small doses of steroid from day 1 or 2. And to my mind, when virus replication and proliferation is going on, putting them during that first week on steroids is counterproductive. It completely makes your immune system go haywire. It completely, and you are promoting more viral replication and thereby more disease progressing and causing more severity. So misuse of steroids has been one of the major contributors to a rapid deterioration in a lot of patients and even young patients.
Thank you, sir. So far as we have seen that the disease course also was quite unpredictable. Initially in the first wave, after 7 days, 10 days, when the patient is just traverse the course of 10 days, we thought that, okay, patient will come out from the crisis. But now in the second wave, after 14 days, 17 days, 20 days even, the patient may again having fever or short of breath, even hypoxemia also. So
you are absolutely right. And that's what I'm saying. That has happened because you give steroid in initial 4 or 5 days, and then you stop steroid because he becomes asymptomatic. And for next 5-7 days, he is doing fine. And then he again starts having this problem. So one of the factors contributing is that. Of course, we will have to really again see what number of patients had this kind of a behavior. But by and large, majority would still have worsening on day 7 to 10 or 11. And if you pick them up at that stage early and start appropriate treatment at that time, which we did not have in March, April, May, June last year, it's only after that that we started steroid and we started getting good results. So here also, my observation is this, and in this way, we have not used much plasma until unless a very specific group. We have not used much of even remdesivir. We have not used much of even the so-called inhibitors like tocilizumab and etc. much. And with steroid and with good intensive care, we've been able to manage. But yes, exceptions are there. And there we had issues with managing these patients. So the course has been little different from the first, as I told you, of intense fever, long duration of fever, and sometimes even worsening after 14 days, 13 days, 15 days, which was not seen earlier.
Thank you, sir. We are happy to announce that we have with us Dr. Professor Dhruva Chaudhry. I invite Dr. Dhruva Chaudhry on the dais. He is a senior professor and head of the Pulmonary Medicine and Critical Care Medicine, PGIMS Rohtak, and he is the past president of ICSSM. Good evening, Dr. Kafeel Khan. He is also with us. So our panel is complete now. Now I am putting some question to Professor Dhruva Chaudhry. Sir, may I audible, sir? Okay. Sir, my first question is, early initiation of the systemic steroid, how far it is helpful and in what doses? Dr. Daga have pointed some points. Yeah.
Good evening, Daga sir. And it's always a pleasure. I have privilege to work under him at MC in 1991 for some time. And he too was my expert when I became professor. Thank you, sir. I think what he said was a word of wisdom, actually. Corticoids, the way they have been used, have been both, it's a double-edged sword. One has seen is that a lot of people have been started using it from the day one itself. And where they have been used early in the disease, the first 1 week, we have seen them landing up in a trouble. Especially, they have been prolonging viremia, not only prolonging viremia, people withdrew them relatively by 7th, 8th, or 9th day. A rebound happened, which was far more difficult to control. That is one part. Second is, when we used appropriately after 7th day or so, they have been a great help to us. But again, it wasn't that we use it. In fact, we had a discussion and debate within our own peers in critical care and otherwise that how to reduce the burden of patient load on the healthcare system. And one system was probably developed was to use early steroids. But you look at it, the way indiscriminately it has been used, we are seeing today an epidemic of another jump of cases of black fungus or rhinocerebral mucormycosis. I had a reasonable experience of rhinocerebral, but the numbers which I have seen this time have been just amazing. Now, question to you is when you will think it that we did a Delphi survey, Dr. Daga was part of it also, and consensus was that there's no doubt about it, if you have got a hypoxemia, you use steroids. That is what the recovery trial has shown, and that's what the other trials have shown, that they are of great help because of the pathogenesis. What we have been trying all the time is trying to chase the virus, but I think it is equally important to understand the pathophysiology of the disease. And we know that the damage which happens because of immune responses, in terms of the immune responses which are supposed to protect us, it's a dysregulated immune response. So it is a part of a viral sepsis. That's what you see. So there, when you do see it, that is the time, hypoxemia, there is consensus across the world that they should be used. One. Second question comes where the most controversy is coming up. Is there a pre-period or not where you can pick up and prevent developing of hypoxemia? How much to be used, when to use that, I think that's a bit of a controversy here. But what one has observed and what one has practiced is that after 7th to 8th day of symptoms, if you find that the fever which has disappeared and reappearing, one, or you have a fever which would have settled otherwise, should have settled, again increases, let's say you have 100, 101 fever, shoots up to 100, 300 fold. Along with if you develop a recent onset cough, which resembles much more, though it is not always easy for everyone to pick that up, about the suggestive of pulmonary parenchymal involvement, or simple language that you have developed re-onset cough, then you have developing shortness of breath, or you develop sudden onset hypotension along with shortness of breath at this point of time. And when you are walking, then your oxygen drops. And I will add to it one thing more which we have observed, and I hope my colleagues will agree with me, that this is something very interesting this time we are looking at it. Your features of hypoxemia, because of which you may find may be different. So you may have hypoxemia in different position. Like sometimes we are finding it that you sit down, you have hypoxemia. You lie down, there is no hypoxemia. Similarly, when you lie down, there is a hypoxemia. You sit down, there is no hypoxemia. It tends upon the basic respiratory pathophysiology in terms of the areas which are being flooded, in the areas which are being having a good perfusion and ventilation perfusion mismatching. To cut it short in one word, if you find hypoxemia in any position or that after a 6-minute walk test, then definitely is again that group you need to pick up. And simultaneously, we looked at this as the clinical picture. Now we need to look at it, is inflammation there or not? Now the inflammation is told to us by a number of parameters, but we have picked up primarily in these cases CRP, and CRP, if we are finding more than 4 to 5 times of the cutoff value of that kit, then you need to be careful, because these are the patients, along with those clinical symptoms, are likely to have a problem. And finally, along with it, when you see there's a radiological involvement, we are talking about X-ray chest, but CT is far more sensitive. But if you find there is a moderate involvement in CT scan, how you define? Now you have 2 different scores. One commonly being used is up to 25, another is some institutions are using of 40. So what we are seeing is that if your score is 13 to 14 average, more out of 25. So if you find 2 clinical parameters, 1 parameter of inflammation, we are taking CRP because it is easy to use across the board. Or alternatively, if you find that there is a significant jump in ferritin or LDH, that's what you will see with this clinical picture. And then if you have a radiology which is more than 12 to 13, I will say, then probably you will consider using steroid. Now, the second thing which comes up after deciding which one to use is, if you decide not to use, then you have to be very, very careful and very obviously closely watch the patient. But this is how we have been practicing, and we are using it, and we are collecting the data, and once it is over, we will come with the publication. Plus, when you see, then how much is the dose? Now, the dose requirement we have kept exactly the same, which have been used. So you may use a 0.1 to 0.2 mg per kg of dexamethasone or equivalent amount of methylprednisolone. But what one has realized over a period of time is dexamethasone has a one very big advantage, that when you stop around 10-12 days, then probably you may not have to worry about the relapses and recurrences, which we are observing. Now the data is being collected much higher with methylprednisolone, and that has to do with the unique pharmacokinetic property of your dexamethasone, of a long half-life of 24 to 36 hours, and may stay in the body for 3 to 4 days. This is how we are using up. As far as the acute care settings when patients are coming to up, a trial is going in my department, in our institution. Now we will be expanding it throughout, but we have started up, is that we are using in patients who are hypoxemic, getting hospitalized with the PA to FI to ratio of less than 200 with us. We are using a pulse methylprednisolone of 250 milligram on 3 days. And once we have reached the 3 days, we follow it with the CRP. And then we are going up with the dose of 0.1 to 0.2 mg per kg of dexamethasone, which is the standard national protocol, to see how effective it is in terms of, and it has to be our surprise that this pulse therapy is turning out of observation, but it's an open random label trial. That is what we are using. And with this, we are using less of other immunomodulators, that what Dr. Daga talked about. And I have been a part of the tocilizumab committee of the state. So has been Dr. Daga for Delhi. And we have been amazed actually the number of people from the private practice, I have given you a data for 360 ampoules or vials which you distributed. Out of them, only 16 were asked by the government sector. That means the medical colleges and all. Whereas 290 were asked by the private sector. And when you really look at the BMJ article, practically 1 in 25 are there. Again, please follow it up. So first you need to optimize corticoid therapy. If still you have got associated more than 75, if you have a cutoff value of 10, that is nearly 7.5 times more value of CRP, along with continued acute deterioration taking place on 24 to 48 hours, which suggests that yes, cytokine storm has taken place. And so that is the time we stop doing interleukin-6, and that's what we are following up with the inflammatory parameter. That is one condition where we have been only using, if it has not settled down with steroids, that tocilizumab. And another immune modulator which we have been using, though it is not part of a question, is the role of JAK1 and JAK2 inhibitors.
Interrupt, sir. So in our institution also, we are practicing the high dose of steroid when after 7 days of course of disease, when the patient is hypoxemic, 3 liter, 4 liter oxygen is requiring, and the CT scan shows moderate to severe involvement. But sometimes we are seeing that after giving this semi-pulse dose, that means 250 milligram of methylprednisolone once daily for 3 days, sometimes some patient again deteriorates, land up to the NIV support, and NIV support is required to be increased, and oxygenation is 5, 10 liter, 15 liters is requiring. At this juncture, it is my experience that whenever we are giving tocilizumab, there is some result. We are getting some result just on this juncture. So, what do you comment on that?
See, I said it right in the beginning to you that optimize the corticoid therapy. We are doing two things at this point of time. When we see, you see, we are monitoring three things. We are monitoring clinical parameters, we are monitoring physiological parameters, and we are monitoring lab parameters to look at inflammation. So that is very important for us. And what we're doing at that point of time is very clear, as you've said it, is that if you see that if there is a rapid decline in the parameter of inflammation, we are comfortable shifting back. And we try to use, if we are using methylprednisolone, when you cut it down in a trial, that is what I told you, but we try to use 2 milligram per kilogram, 1 to 2, so a higher dose for 2 to 3 or 4 days. Then we stabilize it and then come down. What is happening is that we quickly attack it, and then you try to come back. That is the time when the rebounds are there, one. Secondly, I agree with you. That is also the time when you optimize the steroids. You are finding that the CRP is not going down adequately. If we are finding continued high CRP or paradoxical increase with deterioration, that is the time, or along with it, we are finding fever is there, which is a sign of inflammation. At that point of time, we tend to use tocilizumab, and the results are very gratifying at that point of time. If you use early, you use late, you end up creating more infection, more immunosuppression, and more. And secondly, we are also in tocilizumab, we are going up to 4 to 6 mg per kg, but not beyond 400 mg of tocilizumab. We are not giving second dose of tocilizumab in Haryana. AIMS is also recommended the same. And though the national protocol, which has come up day before yesterday, they have written up to 800 milligrams. But what we realized, the trial which we published, Convecta, that wherever we use the second dose, by and large, practically nobody survived. So that is why we are saying with the clinical experience now, and we have that published data with us of Convecta in Lancet, where we have shown, whether I am one of the co-authors of it, where we had actually contributed the maximum number of cases. It's only in a small subset, early or late. When you have acute deterioration, you rule out infection, you're reasonably certain. That is the place where it is playing a role, not a place.
My second question, sir, I'm mentioning one scenario. Sometimes the young chap without any comorbidities coming in 5-6 days with high fever and short of breath and tachypnea. So in this situation, what should be done? Whether we give steroid or not? Because obviously the CT involvement is 5-6 days. Because in second wave, we are seeing that the the CT involvement is earlier, and the hypoxemia is within 5-6 days. We know that viremia phase is up to 7 days. So should he give steroid immediately?
You see, if you see the severe disease criteria in these patients, even if you ask it, symptoms are always much longer, which have been ignored. That is one part. Yeah. But yes, one has seen on patient deteriorating on 3rd and 4th day. We follow the same protocol. We use in these cases remdesivir early. We use in these cases steroids full throttle, straight away go for it. But yes, sometimes we are observing that a clearance takes a time, and this is the one place where you use remdesivir and steroid as described. And the doses, we follow the same pattern as we have done with the rest of the patients.
Thank you, sir. I'm asking Dr. Mradul Daga, sir, one question again. What is your comment about the cocktail therapy or other immune modulator like bevacizumab, infliximab, or itolizumab? They are these things are rampant in the market. The market is flooded with these immunomodulators. In short,
I think Dhruva has placed everything in very good perspective, very clearly when to use all these drugs. And these all came up because tocilizumab was not available in the market. One reason was that.
Yeah.
Secondly, we always feel fascinated, trying other medicines, and we are sometimes governed by these practices of pharmaceutical companies promoting it. So there is nothing wrong in doing that. But if you talk about evidence-based medicine, then probably it is evidence is not there much about other molecules. There are some anecdotal studies published in that, but they are not there with these drugs. But yes, we are having some studies where maybe 1 or 2 not randomized controlled trials where these molecules have been used. Now even baricitinib, the oral drug available 10 milligram. Even that has been used too much in this second wave. And people are claiming anecdotally some benefit with that. But the bottom line is, as what Professor Dhruva Chaudhry said, use it at the right moment. Rule out infection. 1 dose is good enough of tocilizumab. And if patient is critical enough to be on even ventilator invasive, and you put him on invasive ventilator, use it immediately. Don't let be 24 hours past a ventilation. And once you are 24 hours beyond invasive ventilation, the role has been the response has been very, very minuscule. It has not been good. But all these molecules, of course, were used primarily because tocilizumab was disappeared from the market. And that's why people started using. Yes, our DCGI had given permission even in last wave about itolizumab. And some studies were done in our center also. And the results still had to be analyzed, but equivocal. There wasn't anything much. It was itolizumab in addition to all conventional treatment. And results were not very encouraging as far as I understand, but still the data need to be analyzed. So based on that, non-availability, molecule acting in almost similar manner, that's why these drugs have come up in the market.
Thank you, sir. Thank you, Professor Daga. Thank you, Professor Dhruva Chaudhry. So in conclusion, we can tell that the early initiation, early detection, early initiation, and judicious use of steroid in proper dosage is the main thing. And sometimes the tocilizumab, though it is not available at all, sometimes play a role. So next, I shall invite Dr. Kamalesh Sarkar. He is the Director and Scientist, ICMR-National Institute of Occupational Health, Ahmedabad. I'm asking some question to Dr. Kamalesh Sarkar. He's an epidemiologist. So in epidemiological perspective, why this aggravation of why this COVID has been aggravated in the second wave? Do you think that it was inevitable? Is there any geographic variation or there is any mutation? What is the main factor for this aggravation of this second wave on epidemiological perspective?
Yeah. Good evening, everybody. Before initiation, I just want to thank all the organizers for giving me opportunity to be here. Let us discuss a little bit about your question. why these epidemics, the first epidemic and the successive epidemics, or the you say wave 1, wave 2, something, why does it occur? These waves are basically whenever there is accumulation of susceptible population or vulnerable, you can say susceptible population, we find this kind of epidemic. Why second wave number 2 or second wave it came? Because I'm giving little bit background about it. Last year in Ahmedabad, little away from Ahmedabad, there is one district which is known as Mohishagar district. We conducted one study and we collected 2000 samples from there within the month of 6 weeks, within a time of 6 weeks, and we found that 135 were positive. Of them, only 7% had very high viral load, 9% had moderate viral load, and 84% had low viral load. Now, what happens? That means that in a community distribution, out of every 100 infected cases, you will find more number of cases are with low viral load. Now, what happens? This low viral load people, they get mild infection and they get cured spontaneously, and they develop antibodies, protective antibodies for very short duration, maybe 2 to 3 months. So what happens after 2 to 3 months? They become susceptible. So this is the cause of, this is the most likely cause of having our the second wave. Second wave means after this first wave or the first epidemic, a large number, 80%, 85% of them, they had mild infections and short duration antibody, some kind protective antibody. When they declined, they developed the second wave. So what we presume that after 2 to 3 months or 4 months, whatever may be, following this epidemic, this spell of infections, will become, the population of India will become again susceptible for the third wave. So most likely third wave will come unless it is suitably prevented by some effective vaccination strategy and vaccination program. Now coming back to your question, why does it happen? Now, what is your question? Can you repeat it once again? Dr. Chondo.
Yes.
Can you repeat your question again?
Yeah. May I audible, sir? Hello?
Yes,
audible?
Yes.
Yeah. From epidemiological point of view, in different countries, the mutation is different. The case fatality is a little bit different. I can give an example, like a country like Cuba, Vietnam. As far as I know, that the incidence of COVID is much lesser. Though these two countries are not so economically very much rich. So in our country, why this second wave so fatal, and why this second wave came from epidemiological point of view? Is it only due to mutation? Is it due to the malpractice of the common people, or ignorance of the common people, or is it only the lack of preventive healthcare in our country, or is it only due to the vaccination problem?
See, you can say there is a combination of factors. One is we do not have any effective vaccine. Why I am telling, though it may sound little bit controversial, but what we are observing that this vaccine is unable to protect a good number of people. Many of us, we are getting infected after receiving 2 doses of vaccine. And it is also said that this vaccine does not prevent infection, but this vaccine prevents severity of infection. This vaccine prevents death. Now, again, I have certain questions. It should be supported by valid data. Why I am asking this? Because as I have told, more than 80%, 85% of us, we are getting infected by very low dose of virus or the low viral load, which we get cured spontaneously. So the role of vaccine to protect from the severity or protect from death, we need to have solid data in front of us to believe it. So this is, I have this question. And second thing, as you are telling, since and most likely, although nobody has raised this type of question till now, only a limited number of persons have raised questions. some people believe that the role of vaccination is also to some extent responsible for emergence of this kind of mutant strain. Whatever the reason, it may be true, may not be true, but this needs to be investigated properly by collection of suitable data. Whatever the cause, this mutation, the mutant strain, what we are observing is more virulent compared to the original strain prevalent in our country. And as you told, there are other factors combined. There is a lack of, or we are having weak public health system, the weak healthcare delivery systems, and this whatever is this precautionary measures like Kumbh Mela, election rally, all these are combination, all these are equally important for aggravating the situation.
Okay.
But
thank you.
what I want to tell, our country lacks suitable infection control policy apart from vaccination and this awareness of face mask and physical distancing and these things. But apart from that, we do not have any suitable infection control policy in a country like us, where we have a huge number of population, 134 crores population. We do not have suitable infection control policy. What I mean to say infection control policy, see, today we are observing hospitals are overloaded. There is no bed, there is no oxygen, everywhere there is crisis. But had it been a good public health infrastructure and good public health system with us, it would not have occurred. As I told, the basic reason of this large number of infections means there is a massive transmission. We do not have any policy to cut down the transmission from one person to other. As I have told, those who are having high viral load, they transmit at much higher rate. What we observed in Gujarat, that those who are having high viral load, they transmit 6.25% on an average, whereas those who are having low viral load, they transmit on an average 0.8%. That means we need to segregate the cases with high viral load immediately after having RT-PCR report, and all the report mandatorily should mention the CT value, which is an indicator of viral load, which is an indirect indicator of viral load. So once you segregate the cases of high viral load, you can stop or you can prevent transmission to the community drastically, significantly. By that, you can reduce this kind of epidemic. You can flatten the curve much earlier, much faster, if you strictly implement that strategy.
Thank you, Dr. Kamalesh Sarkar. May I ask Dr. Professor Bibhuti Saha, is the Professor and Head Department of Tropical Medicine, School of Tropical Medicine, Kolkata. So I'm asking one question in respect of the answer of Dr. Sarkar. So is there any role, any relation of immunization or vaccination and the mutation of the virus? The more you vaccinate the community, the more the mutation will be there. Is it scientifically tenable? What is your comment?
Well, see, you have to think about the thing in a proper perspective.
Yeah.
So, to protect a community against a disease, what are the weapons you have? You know that we have been talking about COVID appropriate behavior, and with the understanding that most of the general people, even many of us, do not follow that. So, making people behave properly when they are scared, when an epidemic is showing his claw and teeth, then of course now some people are following that. But most of the time, many of us in the people community, they don't follow that. That's the real scenario. So COVID appropriate behavior, you go on saying, but is not taken by all with serious consciousness, seriousness. What else you can do? You can go for a vaccine. And we know that all of us know that it's a history that within a period of less than 1 year, we had vaccines of different platforms. Now, if we talk about our own country, because we know that we had mainly two vaccines, Covishield, which has been developed by Oxford and AstraZeneca, and our own Bharat Biotech has come up with Covaxin. Now, if you look at the chronology of the viruses which have been affecting us, if you look at the chronology, so if the initial outbreak was different, the first wave was different when we had new virus and many of us were exposed and we have been infected, and some unfortunately had fatal outcomes also. Now, when this so-called second wave, which we are seeing now, if you look at what has happened, initially in India, we are seeing the UK strain, B117. Then gradually we started newer strain. In West Bengal, we saw B1618 initially. In Maharashtra, we are seeing B1617. And rapidly, this B1617 has taken over most of the India. Whatever place in India you go now, you'll see this mostly this B1617. And in fact, it has spread outside India also. It has spread to many countries, including UK, Fiji Islands, Singapore, etc., etc. So it has now spread beyond India. And WHO has now, it has denoted this as a variant of concern. What does it mean? Variant of concern means it is more easily transmissible, more severe disease. All of the previous speakers have already told that we have been seeing more serious disease. We have been seeing children being affected, younger people being affected. These are the clinical evidences. And in the laboratory, they have shown that when they are inoculated hamsters with this new strain, the lungs of the hamsters are more severely affected than they were with the earlier strain. So this is definitely more pathogenic. Now, what actually is, basically there has been 8 mutations in the spike protein, including 2 in the receptor binding domain of the virus. And what is this 2 receptor binding domain? They are the sites where they're attached to the S2 receptors. And here the neutralizing antibodies, if you have in the blood, it acts on that. And it has been shown in people who have previously suffered from COVID illness, compared to the previous strains, when they are exposed to this new virus, their efficacy in neutralizing this virus is less, in the tune of 50%, 60%. Some people have done a research on the healthcare workers of Delhi who have got infected after getting 2 doses of Covishield vaccine after adequate time. 3 weeks have passed beyond the second week. And then also they have shown that many of them have been affected with this B1617. So there is definitely this B1617 is now able to overcome the many of the antibodies. In spite of saying that, on the other hand, it has been definitely shown that people who have been vaccinated with either Covaxin or Covishield, they are able, still many of them, most of them are still able to contain this virus. And even if they are getting infected, most of them are getting mild illness. Only, of course, few have suffered from severe illness. And we know even in West Bengal also, physicians receiving 2 doses of Covishield after an adequate period of time had severe disease and we lost them. This has happened. But if you look at the whole understanding that you need to do something, and these vaccines are, of course, giving some protection against the variants which have come. It is the nature of the virus, they will be producing variations. But you need to have something. So what you can do, once you get the new variants, so, and if you look at the immunity produced by the vaccine and by natural infection, the immunity produced by vaccine usually lasts up to 6 months, usually not more than 6 months, whereas the natural infection gives you immunity maybe a little more, 8 months like that. So this is an exercise where you are vaccinating a population to protect most of them. And again, see which new viruses are coming and try to develop a newer version of the vaccine which will cover that component also. It is not that you sit idle, don't vaccinate and allow your population to die. So I am strongly against that. We must vaccinate with understanding that it's not 100% protective, but it will give us most of the people protected. And most of us, even if we get disease, we'll get milder disease. So this has to go on. And at the same time, we have to go on with an exercise of developing newer versions of the vaccine so that the newer variants which are coming will be protected. So there's a war between them and us. And we'll, of course, the only weapon we have is vaccination and vaccination and vaccination. That's my understanding.
Thank you, Professor Bibhuti Saha. His convincing talk regarding the vaccination, regarding the COVID appropriate behavior. First of all, we have to agree and we have to be convinced that the COVID appropriate behavior is the most important thing. The mask wearing properly, hand washing, and maintaining physical distancing. And after that, the vaccination. As per Professor Saha, after the 6 months or 10 months or 12 months, one booster dose or newer vaccination may come and will protect the people. So vaccination is must, and change of vaccine will be done subsequently. I am asking, sir, is there any difference, any confusion regarding Covishield and Covaxin? What is your comment? The WHO is telling that we are not recommending Covaxin. Covaxin is not in our list. So, is there any comment?
Well, I think India is a big country, and we have enough scientific strength in our own system. So, with everything being said and done by WHO, we should go by our own data. And our own data as it has been made in the public domain, because I am not personally immunologist. So whatever I am talking is on the information available on the public domain. It has been shown that this Covax, if you compare the efficacy of Covishield and Covaxin, Covishield efficacy is 68 to 70%, whereas Covaxin, it has been reported to be 81%. And also, it has been claimed by ICMR that because it's a whole virus vaccine, so it produces antibodies in all the viral proteins, spike protein, receptor binding domain, N protein, everything. So it is expected to be expected. I again state it's expected to be acting better against many varieties of the virus. And even whatever the variants, most of the variants are supposed to be better covered by the Covaxin. With this, I just had a very small study. It has not even been published, but they are saying that whatever vaccine you use, with the duration, when the duration of vaccination, after the duration of vaccination is more than 6 months, the vaccine-induced antibodies drops, whether it's Covishield or Covaxin, and make yourself more susceptible to new infections. But still now, as per the available information, Covaxin, and also our experience, though in our state we have used more of Covishield than of Covaxin, initially we were very hesitant about which vaccine to use. And some people were thinking that billet is from England, so UK, so it must be better. And there are initial hesitance on taking Covaxin. But if you look at the side effects, Covaxin has possibly been better tolerated. Many of our people who we know, they had serious allergies to many things in the past, where they're very hesitant to take vaccine. But Covaxin has been given very safely without any various risks. Though we had some serious side effects, but that's less than 1 in 100,000, and that's more for Covishield. So possibly Covaxin is better tolerated. Efficacy, well, we need to have more data to comment on that. But I again insist on saying that WHO, yes, of course, they are a parent body, but we know WHO has made many comments which have not been substantiated by observation. So I'll stop by saying that we should go by the Indian evidence, and we have enough strength, and I have personally have enough belief in whatever we Indians do. Thank you.
Thank you, sir. My last question to you, sir, one virus, but different symptomatology, different outcome, and different geographical variation. Sir, what is it, sir? Is there any comparable virus, such a variation in symptomatology, different outcome? Is there any other virus, do you think, other than novel coronavirus?
Well, you see, if you look at look at the point at this angle, that has there been? I think your question is, has there been any other additional factor involved? So co-infections, co-infections with COVID. Well, there have been some co-infections, but they are not so very many to change the clinical picture. I think if you compare the clinical picture,
I'm not asking about the co-infection. I'm asking that one virus, but it affects multiple systems and different age groups they are affecting. And in first wave, the symptomatology is something. The second wave is something different. The age variation also something different. Why this, sir? And according to the geographic changes, the course of the disease is also different. Why these changes, this variation?
Well, one of the reasons can be India is a big country. So very big country. We have, the people of Punjab, they are so long and tall, and we in the eastern side of the country are relatively smaller, shorter. So physical infrastructure, some genetic makeup, of course, that may be that may make some difference. And if you look at age-wise differences, well, as my previous speakers have also mentioned, that children are being affected more this time, and we are getting some serious illnesses in children. And of course, younger people we are seeing more being affected this time with the very severe disease. One of the reasons for that may be that the vaccination of the elderly, so younger people has not been yet brought, only the 18 plus has just been started. So younger people most of the young generation are yet to receive a vaccination, so that maybe they're not yet protected. So I think these are the if you think initially the strains were different in different states, and now all over India mostly is B1617. So clinically there may not be very much of a difference. So the basic difference, minimum difference which you see maybe because of the genetic background of different populations and underlying associated comorbid conditions, diabetes and all those things. But overall, I think to me, Indian picture is overall almost similar, not much of a difference in different parts of India. Okay. And also the infrastructure. And one important thing I missed to say, one thing we are seeing this time, the first epidemic were more concentrated in urban areas. This time you go to any interior areas, you can see people being affected. One big reason, as my previous speakers have also told, that we had election puja. So all parties, I am not naming anyone, but we did big rallies and people went there, people from villages, innocent villagers went to the rallies and they came back with the disease. And unfortunately, it has gone to a very, so this is something which pains me a lot. I, like many of us, we feel a lot of pain that much of it was avoidable. And what is happening in the rural settings, people are not going to the doctors. They are having cough for maybe 7, 8, 10 days, just taking home remedies, village quacks. And when they're very serious condition, then they are going to the health facilities. And the facilities maybe in the distant areas, far away areas, may not be that enough competent to manage them well. So that has also contributed to a lot of morbidity and mortality. So that's again one point. Thank you.
Thank you, Dr. Shah. And now I am coming to again Dr. Kamalesh Sarkar. My question is there any definite policy of the dosage interval of the COVID vaccination? Sometimes initially we have heard that the 4 weeks duration, 4 weeks interval in between the two doses, then 6 weeks, then 12 weeks. Now it is 9 months, 8 months. So what is the science behind this interval of the two doses? Please tell us. And another question is, whenever anybody is suffering from affected with COVID-19 infection, what is the gap? What is the interval he has to maintain to take the second dose or first dose?
See, I am giving answer of your second question first. Usually, as per CDC guideline, once somebody is infected, the vaccination should be deferred at least 3 months. That means 12 weeks. So after 12 weeks, he can get vaccine. And regarding your first question for Covaxin, it is fixed. It is the 28 days or the yes, it is 4 weeks. For Covaxin, it is 4 weeks gap that is fixed. It has not been increased. But for Covishield, initially it was 4 weeks, then 6 to 8 weeks, and then further. Further, it has been widened. The gap is widened. The reason behind it in Britain, as far as I understand, in Britain, they also had shortage of vaccination because it was in the production and there was a huge requirement. So they deferred it by 2 weeks, and they observed that there is the antibody titer is much higher and protective titer is better. So based on that, in our country, they have extended it from initially 4 weeks to 6 to 8 weeks. But now it is further 10, 12 weeks, something like this. Probably that is because of our production, related to some delay in production.
Thank you, Dr. Sarkar.
So whatever the reason, yes.
No. You continue.
So for Covishield, now it is 12 weeks or more than 3 months. Probably it is related to our vaccine production, delay in vaccine production or something like this.
Okay. So any comment from Professor Daga regarding this increasing of the interval in between the two doses?
I think, as rightly said by Dr. Sarkar, one is the government decision. But again, initially Covishield studies have shown, and they had published a paper showing that they suggest, in fact, even more than 7-8 months back, I mean, 6 months back, they suggested that you take one vaccine and the second dose should be after 12 weeks. That was a recommendation from a small study they published, where they even gave initially not the full dose, even half dose first, and then second dose after 3 months, and they found good response in terms of antibody developing in the individual. So based on that, probably there is definitely that one paper from the AstraZeneca, and that has helped us taking that decision, because that will allow us to include more people in vaccination. And further, one can only comment when you have a large database, but yes, that's one of the reasons that they've done it. That there is an evidence by a small study by AstraZeneca itself, which showed that 3 weeks. In fact, in UK, initially they were vaccinating after 4 weeks, and then after this data, they started the UK health authorities even thought that we should only first vaccinate all the population and let's give the second dose after we are able to give that. So that kind of practice also subsequently was adopted in UK, where they give the interval would increase to more than 12 weeks there as well.
But this, sir, the Oxford AstraZeneca told that the 12 weeks duration is optimum. But nowadays we are seeing that the 16 weeks, and probably in the month of June it will be in that.
I think let us not be skeptical about it. I mean, 16 weeks is no evidence as such. Yeah. We know that. Yeah. 12 weeks is appropriate, and I think we should write to our task force and our national agencies that yes, we should not increase that duration. Either you think that you produce partial immunity with one dose and let us immunize everyone with one dose only, then probably it will be a scenario which will be very difficult, you know, because that's what we are saying, as Dr. Sarkar was saying, or he was saying that if you have vaccinated a group of population above 45 or above 16, that's why you're seeing now more younger patients in this wave, because they were not vaccinated. So let us not do that.
Thank you, Professor Daga. I am now coming to Dr. Kafeel Khan, who is a very popular figure in India. I am inviting Dr. Kafeel Khan. He is a pediatrician, and he fought for the oxygen, and he saved many lives of the children in BRD Medical College in Gorakhpur, UP. I'm asking regarding the oxygen scarcity of India. Is it inevitable? Is it inevitable, oxygen scarcity throughout the India? Our developed country.
Hello everyone. There are so many seniors are there, and I'm really hesitant to speak anything. Sir, very senior. If I am in a medical college or in a hospital, I would not able to open my mouth in front of these legends. Good evening, everyone. Uh,
Good
Oxygen
evening.
scarcity in this what I have seen in month of April. It started on 20th April and finished on 5th of May. Like 15 days, India grasp of oxygen. The metros, especially the Delhi, Mumbai, Bangalore, Chennai, Lucknow, Kanpur, everywhere there was a chaos, and it was like a deja vu situation for me. What I have witnessed in BRD Medical College for 54 hours, the whole India witnessed for next 15 days, and so many lives have been, that's why I said that dying because of oxygen shortage. It's not dying because of the COVID-19. It's a murder. Uh, uh, yeah, you can say that India is a large populated country, and we didn't expect this wave this severe. That's why we were not prepared how much oxygen we needed. These are the excuses, I would say. I would just say the Indian government caught napping. They went into pandemic fatigue or maybe sleeping mode. They declared victory before they won the uh, coronavirus waves. The whole world witnessed coronavirus. The UK and US has the worst second wave. We have seen US during Trump regime 4,000 dead per day and 3 lakh cases per day. But still, we were more busy in like 5 states election year: Paschim Bengal, Kerala, Tamil Nadu, Assam, Pondicherry. We allowed large religious gathering. I just want to know how many oxygen plants we have made. 168 PSA pressure steam absorb oxygen plant was cleared by cabinet in April 2020, and it took 8 months to float the tender, and next 4 months they took to approve the tender. So at the end of 1 year, from April 2020 to April 2021, they established only 5 of them. So this is the situation, and we were so busy till 2nd of May. If you remember, the oxygen supply started resuming only after 5th of May. So only when the election results were out, and the government started in a war foot zone. So it was a tragic. It should not have happened. I would not say it is inevitable. It should not have happened. So many lives have gone, and this is the situation we witness in the metros. Just imagine what would have happened in the villages. We are doing one doctors on road campaign, and we're going to the peripheries, and we are witnessing that the primary health center, which is the backbone of any health system, it is already collapsed. It's not there in UP, Bihar, or Rajasthan, Madhya Pradesh, anywhere. This so-called cow belt. So imagine where there is no RT-PCR, forget about RT-PCR or rat test, no hospital facility. How many people would have died? We saw this oxygen scarcity because the digital media, the electronic media, everyone were concentrated on these metros, but nobody is talking about the periphery, what is happening.
Thank you, Dr. Kafeel. So, Dr. Kafeel is pointing about the infrastructural lacking, the poor infrastructure throughout our country, and the main problem in the primary healthcare system. There is collapsing situation of the primary healthcare system. So, one question to Dr. Kafeel: was there any scope to divert the industrial oxygen to medical oxygen, or to use the industrial oxygen in medical facilities? Was there any planning, or is it scientific? Because we know that in industry, oxygen is used very much. Yeah.
I would start with your collapsing system statement. I would just say it's not because of the COVID, our health system has collapsed. COVID has just exposed our health system, our already collapsed health system, So our health system was not in a good shape before the COVID itself. And about the industrial oxygen, you say, yes, we can use, 7,000 metric ton. This is the production. Only 1,500 we are using in India as such. But now when the demand increased to 8,000, 9,000, then they started diverting, and then they started importing. So even the IIT Mumbai has, they have changed the nitrogen PSA plant to oxygen PSA plant. So we can use. I think we can use. The thing is that the whole health system suffered a lot, and for the past 75 years, I would not say that only Modi government has ignored our health system. And for the past 75 years, each and every government has ignored our health system. We are spending only 1.25% of GDP on health expenditure. When the whole world is spending around 6 to 8%, and even in post-COVID era, most of the countries are spending 10% of their GDP. But we still, even though we announced 35,000 crores for vaccine, but where are the vaccines? So, Dr. Biplab, you must be remembering we started this Health for All campaign, in 2019. It's already 2 years, and I gave this proposal to Dr. Harshvardhan also, to how to improve our health system, but still nothing could have done, even though they promised the same. India has become, third largest country where people live with HIV and AIDS. India has become diabetic capital of world. 5 lakh people are dying because of tuberculosis. Okay, there is a data which says in 2020, 1.5 lakh people died because of COVID-19, but them 1.1, 1 crore 10 lakh people died because of non-corona diseases. So those diseases have not finished. People need dialysis. People have delivery problems. People have if there is a myocardial infection, the OPDs are shut. They are taking care of COVID-19 only. So we have failed, and our administration has failed.
Yes, you are correctly saying that the non-COVID treatment is grossly neglected nowadays. My last point to you: what is your warning regarding the children? Because we come to know that in the second wave also and impending third wave, the children will be affected, and they will be fatal. The children will be fatal. So, what is the warning to the parents to save our children, our daughter, our son?
So one thing I want to tell before starting answering your question. Right now, sir has clearly said that this virus will mutate. There will be waves. There will be third wave. There will be fourth wave. There will be fifth wave. There will be sixth wave. There will be seventh wave. If you remember, when the first UK strain was noticed and published, there was so much hue and cry and media frenzy. But we knew that there will be so many strains. Now there is South Africa strain. There is a double mutant Bengal strain. So mutant, this is a virus. Like we have influenza virus, and we have to take vaccine every year for influenza. The same way virus will mutate, and there will be thousands of mutation, and there will be hundreds of waves. So we don't have to worry about. Yeah, okay. The virus pattern is like that. It's hurting more younger population in each wave, because the way we are protecting ourselves with the wearing masks and trialing so many drugs with the vaccination drive, the virus is also behaving like that. Every human body virus, in fact, it's a lab for them. It's a laboratory for them. Our virus will change themselves to resist anything you want to do. In first wave, only 5% of children was affected in India. In this wave, 20% were affected. And this year, around 1.25% mortality is also been published. So we are worried. It's not because of certainty that the third wave will hit the children. It's not because of that I'm worried, because who knows the virus what is going to do. Okay, this is just a mere assumption, or maybe more flow to maybe by pharma companies or big people. I am worried because how many pediatricians we have. According to the guidelines, there should be at least 1.35 lakh pediatrician in India of 1.35 crore, like 1.35 billion population. At least that. How many pediatrician we have? 32,000. India doesn't have so many pediatric ICU. You go to any big hospital, even in Kolkata Medical College, you will have only 8 to 12 PICUs, pediatric intensive care unit. So how many pediatric intensive care unit you have? How many companies they make pediatric ventilator? Only 2 or 3 companies in India they make pediatric ventilator. So we have a huge shortage of infrastructure, huge shortage of manpower. We have to train, like we can't consider children as a miniature of adults. They are totally different. They're totally different. The physiology may be same, but the drug reaction and how you treat the symptoms and signs to their children. I have seen in this COVID, some children just have vomiting and diarrhea, and they become COVID positive. No fever at all. Some children will have just lethargy and excessive cry, and we do COVID test and it become positive. Some children will just have conjunctivitis, and we did a COVID test and it became positive. So they are totally different. And we don't know all the drugs you are talking about, tocilizumab, remdesivir. It's of what we have not tried it on the children. We have not given it to them. And then there is no vaccine. Okay, Pfizer is giving a name. Bharat Biotech is also going to start from first one, but we don't have vaccine. So all those 5 factors, we don't have manpower, we don't have infrastructure, we don't have vaccine, we don't have drugs. The children are not already encountered with the virus. They are little, naive to the virus. And for virus, it's a new body, so it's proliferate. So now how we will prepare ourselves? I think so. At least what I have already suggested, that at least 25% of ICU, and this 25% should not be cut down from the ICUs. 25% of PICU bed should, ICU bed should increase, and that should be converted into PICU. The more pediatric ventilators should be used. And because doctors should be trained to run a pediatric ventilator, because ventilator, Dr. Biplab, everybody must be using ventilator, and ventilator is not some toy. Okay, any person can just use. Like in Karnataka, they gave dentist to run a ventilator. That will create we need at least 3 years, of experience to run a ventilator. At least maybe 6 months. You have to change the PEEP and PIP and FIU on the basis of ABG. So we have to train this manpower to run the ventilator. We have to train. We have to make PICUs. And for the parents, I want to tell that start preparing your child about the personal hygiene, how to wash your hand. Only 3 ports are there. We know that mouth, nose, and eyes. And most of the children, especially less than 5 years, they have a habit to put finger in nose, put finger in the mouth, rub their eyes. So tell them, don't do that. Don't do that. Don't do that. Every time they do, Tell them, because this is the basic thing. Once you know, a student will start learning maybe after 3, 4, 5 months. You start telling today, they will maybe after 4, 5 months they will increase. Then increase the immunity. Children has the best immunity, but even we don't know why how the virus will behave. So how to increase the immunity? Don't give bonvita, this Complan. Give
Horlicks,
food. All this complaint. Give food. Balanced diet. There should be fresh fruits. There should be dried fruits. There should be wheat, grains, everything. I have suggested as a pediatrician, I will just take 100 grams of 100 gram of groundnut, 100 gram of any lentils, and fried it, and then mix put it make it like a powder and put it in milk and serve. So this will be the increased protein. There will be a increased vitamins, and every children should be vaccinated with influenza vaccine. Influenza vaccine, I'm telling you specifically influenza vaccine. Every children who are less than 15 years, they should take influenza vaccine, especially if they are hyperactive airway disorder or asthma child. Because once this cold season, we are expecting the third wave in October, November, December, when we see a lot of child with a breathing problem, hyperactive airway disorder and bronchial asthma cases, and it will be a difficult. And influenza do give some protection against bronchial asthma and this common cold. So it's better to give the child influenza vaccine. Yes, sir.
Thank you, Dr. Kafeel. I am inviting Dr. Professor Sukumar Mukherjee, my teacher, a legendary figure all over India. I am requesting sir to say something how to prevent the third wave, and we are very much eager to know your message regarding this case fatality in the second wave, how to prevent the third wave, regarding vaccination, confusion regarding the vaccination. Please guide us, sir.
Thankful to combat COVID for giving me an opportunity in presence of brilliant speaker all over the country. I have been listening with rapt attention to all the speakers for their beautiful expression and their practical experience how to deal with the patients with the COVID. But I have got a different angle to talk about. When we talk about combat COVID, let us take it a kaleidoscopic view of COVID-19 2020 and COVID-19 2021. In the 2020, science was evolving, and this combat COVID was a new thing to us. At that time, this COVID-19 has put up a challenge to the human race and put up a deadlock to our healthcare system, both in developing and developed country. And if you look at this 20 picture, that you will see with our evolving science, emerging facts and figures, we thought that disease is centered at the elderly people. We thought we need to somehow strengthen the public health system by putting more of gloves, more of masks, more of PPE, and more of sepsis infection control. In this 2020, we learned about multiple drug therapy. As for example, anti-roundworm, antibiotics, vitamins, immunity boosters, steroids, and many antiviral drugs. And lastly, the virus in those times did not have any variants, and now they have come with the variants. And lastly, there was no vaccine in those days, and we have got vaccine now. We are in the middle of the crisis. And actually, what we find, there is a paradigm shift in 2020 and 2021. And if you look at this profile, I think in the month of January and February, we are very inert. We are very relaxed. And the 10th of March, West Bengal figure shows infection rate of 224 cases and 2 deaths. Since 10th of March till April and May, it has staggered up, and staggered up is gone up, and as a result of which we have seen the picture of 19,000 cases a day in West Bengal, with the death rate coming around 150. And then after lockdown, there is a decline of the cases. So lockdown has a sobering effect in the control of the disease. This is a proven method by which you can control the disease. On the other hand, the vaccine has got more control of the severity than transmission of infection. COVID-appropriate behavior is also influence over the control of the transmission. In any case, we must break the chain of transmission. That is the primary model of treatment. But one thing is very important before we go into the picture is the most basic concept or benchmark is testing, testing, and testing. Testing and tracing are the yardstick to study the magnitude of the problem, to get accurate idea of the case of infection, to get an idea about the mortality rate, and testing also reveal some of the asymptomatic cases. So obviously testing to the point of up to the serosurvey, to the point of genomic surveillance are the benchmark to study the epidemiological pattern, to study the morbidity pattern, and to study the mortality. Unless we have got the accurate data, I think we are in the false premise of artificial numbers, what we are having. Many people abroad are doubting our figures, though we do know that India has got a low mortality rate of 1.1 to 1.4%, whereas the United States and the UK, they have got more than 4 or 5%. But they are doubting our figures. I think testing is the most important part to study any disease process, particularly infectious disease. Next comes there is a paradigm shift where we failed. Dr. Daga has nicely elaborated the factors which led to the emergence of the second wave. What we are doing in the month of January and February, we are all relaxing. Vaccination strategy was inadequate. COVID-19 behavior is inadequate. More so, there are Kumbh Mela, and in West Bengal there are a lot of political rallies, so also in Kerala and Tamil Nadu. So obviously these all led to the increasing height of the cases, and we see the picture, what is April and May is nothing but the aftermath of our irregular behavior, inadequate vaccination, and inadequate appreciation of the severity. Now the virus itself is much cleverer than us. That's why they have come with a different color. There is a variants. Variants all started in the UK with UK strain, particularly from the Kent. Then it went to South Africa. Then it went to Brazil. Then it has come in India. And double mutant is the first reported from the Maharashtra. And this is now ravaging all the country, particularly Indian population. And we are alarmed with the COVID-1617 subtype 2, which is causing much more damage than what is happening elsewhere. In fact, this has gone to the other 40 countries in the world, and UK has stopped the international flight because of 1617 subtype 2. Fortunately, the vaccine has got a control over it, but still this variant have got an immune escape phenomena. And this immune escape phenomena results in the occurrence of infection even after vaccination. I have got personal experience of treating patients who are more than 90 years of age with a double vaccination, but he came out successful because this does not control, vaccination control the severity and not the transmission. So we are unable to break the chain of transmission except restricted movement, except lockdown, except curfew or micro-containment or containment in general. So this is the scenario. That's why we are very lazy at that time in the month of March, and we got the results in the April, May. Now it is after lockdown in West Bengal for 15 days, then 19,000, it has come down to 16,000. From 16,000, it has come to 13,000, and it's come less than 12,000. So it is showing the benefit of lockdown. That means people are not mingling with the other people with protection, without protection. So obviously this is the scenario what we have got in West Bengal. And in addition to that, what we see, the vaccine arrived. Vaccine arrived in January, and I'm the first person in West Bengal to get the first vaccination dose. And I completed the second dose in the month of February. So I had a 4 weeks gap as Covishield theorized. Now Covishield backtracked, and Covishield has gone to instead of 4 to 6 weeks, 6 to 12 weeks, if not more. So obviously, it is scientific truth about 80% success, or it is going to accommodate more number of people by increasing the gap between the first and second vaccination. Remember one thing, this vaccination is control the mutant as well. But one is the immune escape can still happen, particularly from the spike protein. And you can see the vaccination, we started all with hesitancy. Then we had a vaccine diplomacy. Then we have got vaccine complacency. Vaccine diplomacy, why did we send the number of vaccines to other countries? Keeping the people away from Indian population to a benefit of vaccination. Now we are hungry for vaccination. We are hungry for oxygenation. We are hungry for the hospital beds. We are hungry for how to control transmission and how to control death. Even in 2021, we are more mature in terms of knowledge, but our action is not that supporting our mental thought. So obviously, we have got the vaccination program is delayed. Initially, it was thought that is liberalized vaccination, universal vaccination, or restricted vaccination. Vaccination came with a priority group: healthcare worker, social worker, and elderly people. At that time, it was thought possibly we are thinking more about elderly. I'm being an elderly man, elderly, and obviously the elderly protection is a priority. Now they have changed the concept from the priority group to super spreader group. The super spreader group involved many professionals, particularly the loitering outside the house, in the marketplace, in the bus station, in the cinema hall, in the mall, everywhere. And obviously now we are concerned the super spreader vaccination as a way out to stop the further spread. And that is, but in that setup, we don't have enough of vaccination. I think in India, we have got 130 crore of population. But unfortunate to see the 20 crore population has been vaccinated in India. And West Bengal, we have got vaccination of 1.4. So obviously, we need to scale up the vaccination in order to stop the third wave. Third wave can only be stopped if we again become very lethargic, lackadaisical in our approach to vaccination. Universal vaccination is the rule, then the exception, including all age group, because it has been shown in smallpox, in polio, the herd immunity. Why it goes late? When Western countries have developed the vaccination for polio and smallpox in early 60s and 70s, we started the vaccination for 70s and 80s. And smallpox vaccination, polio has worked well. But in this case of corona or COVID infection, our vaccination supply is inadequate. People, a large number of people. And in India, about the 60 crore people to 70 crore people are a young age group. And they are the real super spreaders. And obviously, vaccination has to be covered for these people in order to save and get the herd immunity. Remember, herd immunity, talk about the herd immunity is not a fixed number. We always talk about 60% people to be vaccinated go to herd immunity, but it's very flexible. Look at the program in the Seychelles Island. They have given more than 50% people vaccinated, and they thought they have eradicated the COVID-19 infection, but ultimately they fall back. And now they are following the path of more vaccination and more protection, appropriate behavior of the COVID-19. They stopped using masks, and that is the lesson we have learned from the Seychelles. And obviously in India, we need to affirm vaccination followed by protection by appropriate behavior, and that will continue. Why? Because a person who is vaccinated, he is safe. but he can transmit the infection to others. And if you look for the R value was very high in India. Case fatality rate was low in India. So obviously the R value determines the magnitude of the problem, and that magnitude of the problem is just so serious. We are reaching in a pandemic. We have lost so many doctors. We have lost almost many people in India because of the sheer ignorance, sheer lethargy in the initial phase of the year to vaccination, to enhance vaccination, or to follow the appropriate behavior. Why did we allow Kumbh Mela? Why did you allow the political rallies in 3 states? And that resulted in a massive increase in Kerala, Gujarat, Maharashtra, Tamil Nadu, and West Bengal. So this is the way the situation in vaccination. Now we are looking for the 3rd wave. I'm sure if you go in a lackadaisical manner, then we will again face the 3rd wave. What precautions to be taken in the 3rd wave? I think one important feature, now we are again learning. We have in the COVID vaccination, COVID-19 has involved the elderly, COVID-19 people has infected young people and middle-aged person, and now it is hitting the kids in 3rd wave. That's why universal vaccination is the slogan. This is the most important part we must stress. Even childhood vaccination has been given in trial in 12 to 18 years of age, even less. Even in children, the parents need to be vaccinated. If you want to open the school, parents need to be vaccinated, teachers need to be vaccinated. So unless we vaccinate the children, parents of the children, how can you keep the children in the hospital without a mother? So remember this. And many children are losing their parents. Now we have got a larger number of orphan children who will look after, how to help them, how to give them the support. These are the burning questions. Lockdown has got a good effect on the transmission chain breakdown, but it has got an equally disastrous effect on the economics of the India. That's why lockdown is a two-edged weapon, just like steroid is a two-edged weapon. So obviously we have got, these are the scenario, and for the 3rd wave prevention, I think we must vaccinate all, improve our public health service. Public health is always ignored because clinical science and clinical care gets immediate result. Public health service gives late results. So we have to improve or enhance the public health service to a great extent. And we must go for the time to update our hospitals. At least in West Bengal, I can quote, there are 21,000 beds in the public capacity. Plus, there are 6,000 beds in the private capacity. Taking all together, we have got 25,026. But if you look at the scenario, now the COVID-19 is spreading from the urban area to the rural areas. In West Bengal, North Chobbish Pargana is very much hit, followed by Kolkata and Howrah. So obviously, we must look at the district level. And I'm sure in all over the country, district level support system is not that adequate. Vaccination is not that uniform. And testing facilities are not that uniformly successful. So we must look urban and rural. They are closely proximating. So obviously, we cannot ignore the district hospital. We cannot ignore the rural Bengal in order to support the human being to a better life. And in addition to that, we must also, there is a COVID tracker. Now with the COVID tracker, if you use it, I think you can also get the people who are asymptomatic or mild cases. And that's why we need long-term data on the serosurveillance. We need to have a genetic surveillance. We need to have eco surveillance. Unless we have got these studies which are preventive in nature, we cannot offer the best quality care for the patients of COVID-19 infection. And lastly, that is what I like to say, that preparation for children. I'm sure in all states and West Bengal have got the similar picture. What about we have to make a task force for children or for the children suffering from COVID-19. We have to prepare the hospital with the PICU, NICU, and SNCU. We need to have parents to be vaccinated. We need to have oxygen support. Pediatric ventilator is not the same as adult ventilator. So we have to have some good support of pediatric ventilator to prevent the third wave. And lastly, we must have home care. What are the fallacies of home care? Home care is a good for economic reasons. Home care is good for mild and symptomatic cases. But for the elderly, it is not the boon, but it may be a bane. And obviously for the home care, we need the telemedicine service. That is very important. That is not uniform. GPs to control the patients, and sudden deterioration of the respiratory function, sudden fall of oxygen. That's why we had a formula SCRB 60. 60 plus age, look for the oxygen saturation, look for the central chest pain and confusion, look for the respiratory rate, look for the blood pressure before they get into acute crisis. That's why hospitals are getting late cases of elderly people having sudden death. And that is why if you stratify the patient, make a triage of population on the people suffering from COVID-19. And that triage must include severity detection, mild, moderate, severe. And that will give us a bonus to treat the patient early. Last one, what is not being stressed, the arrival of mucormycosis, which is tragic. It all started in Maharashtra. And now we have got more than 7,000 cases over the India. And West Bengal has got only 18 or 19 cases with 2 deaths. So obviously mucormycosis. Now we are all talking about the diabetes and steroid use and steroid abuse. Why it did not happen in the last year, in 2020? Why it has happened now? Have you become very careless about the steroid use? I think it was there, it will be there, because diabetes and mucormycosis are very much interrelated. I think our prescription has become narrowed in the treatment of COVID-19. And last but not the least is the abuse of antibiotics and misuse of antibiotics. That is a dreadful thing to cause antibiotic resistance, carriage of fungal infection, and as well as this antibiotic is a cost. Have you seen the private hospital cost? For 7 days stay, 3 lakhs. For 2 weeks stay, 5 to 7 lakhs. And 3 weeks stay, more than 30 lakhs. I, being a member of the commission, we have got the experience how the private hospital escalated the billing and the people at the cost of life. They lose the patient and they lose the money. So obviously, we need to have a strict disciplined attitude and monitoring of the patient both in private and public hospital, and make it patient pro patient, so that we can stop misusing drugs, restrict our treatment. Assessment is more important. One thing you must realize, the doctors are also fatigued. For the last 2 years, doctors are fatigued. How they take care of the COVID patient, that need to be seen. I cannot blame the doctors. We need more doctors. We need more personnel to treat the patient. So effectively, as per discipline, then we can control the disease. Otherwise, we are going to face the third wave, if not fourth wave or fifth wave. Thank you. Over to you.
Thank you, Professor Mukherjee, for his brilliant deliberation, which is concrete, which is lucid and bold one. So again, I am thanking everybody on behalf of our organization, Medical Service Center. We are organizing community level program to prevent the transmission and to provide the home care, to provide the medical help to the rural people. We are doing so many programs. So before ending this brilliant webinar, I am requesting everybody to give their message in 1 minute, please. First of all, I am inviting Professor Dhruva Chaudhry. Please, your message to the people in India in 1 to 2 minutes. I'm requesting Professor Mradul Daga. Sorry. I'm requesting Dr. Bibhuti Saha.
Well, thank you. Am I audible?
Yes, yes,
Okay.
sir. Yes, sir.
So I will say 3 points. Number one and most important is increasing the vaccination as much as possible, as early as possible, getting vaccine from other sources so that we can vaccinate as many persons as possible in a short span of time. Number two, thinking about newer vaccines because we'll need newer vaccines, newer versions of the vaccine. So research must go on. Preserving the infrastructure because what has happened after the first wave, we have dismantled everything and again we are started building up. So we need to make a plan for future so that we preserve some of the infrastructure. And finally, COVID appropriate behavior is more easily said than done. And I would like to suggest at this point of time that many common people, they don't have masks, or so we can think of the distributing masks to common people who are found not wearing masks from the government system. So that can be something which can help us. So these are the few things which are coming to my mind. Thank you.
Thank you, sir. Thank you, Dr. Saha. I'm asking Dr. Kamalesh Sarkar within 1 or 2 minutes, please.
Yeah, I just like to emphasize on transmission, prevention of transmission, because our country, our health system is not equipped enough to handle so many cases as observed in the second waves. So transmission, prevention of transmission is the most important, and viral load is the most important, which is indicated by CT value or cycle threshold value. This must be stressed, and all the states and as well as the center should adopt this infection control policy using high viral load and transmission chain, breaking of transmission chain. And second thing, the vaccination is definitely required in this country, but vaccination needs to be redesigned to make it more effective. These are the two messages I just like to give.
Thank you. Thank you, Dr. Sarkar. I'm requesting Dr. Kafeel Khan, your message within 1 or 2 minutes.
First of all, thank you for inviting me for this wonderful discussion. I have learned so much. For me, at least I can say. First and foremost thing, that it's a pandemic, it's a global phenomena. If India is bleeding today, no country is safe. If India is ground zero and the world is watching, and holding vaccine and things are all, nobody will save. And the same thing will apply to India's metro city. If they think that India's second wave has peaked and they're happy now, they have oxygen and bed and they have vaccine in the cities, and they don't care about the poor marginalized society in the villages, in the periphery, the virus will come back again to the city, to your Mumbai, Delhi and all. So you have to take care of each and every citizen, whether it's in India or it's in everyone, all over the world. The second thing about the vaccine, I wonder why we have in Kasauli, Himachal Pradesh, where MMR vaccine and other vaccines, we make around 10 million vaccines every month. Why we are not using Tamil Nadu facility? Why we are not using Chennai facility? Or the government manufacturer? We are now largest manufacturer of vaccine. Why the biotech and Serum Institute of India are not sharing with the other players the formulas? So I think vaccine is one solution, and the COVID appropriate behavior, 2 gaj ki duri, mask hai zaruri. We have started a Doctors on Road campaign on 14th of from 14th of April, when the tsunami came, the second wave, and we have already distributed more than 20,000 masks, and we will continue to do that. But the thing is that the government has to finally understand that, and the people of India has to understand that health is a basic right. It's a basic issue. All the elections are largely fought on the basis of religion, caste, region, and socioeconomic status and all. That should not be the thing. employment, education, and health should be the basic issue. Until unless you are not going to improve your infrastructure, you're not going to train your doctors, you're not going to give the every Indian citizen free of cost health facility at their doorstep, you are not going to develop a good country. So I think people of India and the government of India has to realize the importance of health, and health should be the basic issue. Thank you, everyone.
Thank you. Thank you, Dr. Kafeel Khan. Sir, I am asking Professor Sukumar Mukherjee regarding any message to the medicos. We are losing our colleagues every day. So please, sir, within 1 or 2 minutes, any message to the medicos?
I have got 4 important steps. Number 1, increase the number of tests. Testing, testing, and testing. Number 2, universal vaccination. Number 3, COVID-19 appropriate behavior to continue for next 2 years. And lastly, intelligent way to put lockdown in action. Periodically keeping an eye on the migrant laborers and the economically underprivileged person. These are the 4 messages.
Thank you, sir. Thank you, everybody. On behalf of Medical Service Center, again, I'm thanking you for participating in this webinar. So take-home message is COVID-appropriate behavior. We have to maintain it properly. Early detection and early initiation of the treatment. Judicious use of steroid, oxygen therapy, heparin. Increasing of health infrastructure in India. Vaccination, which can decrease the disease severity, of course. We do not want any central vista. We want vaccination for the whole population. We do not want coronal. We do not want any unscrupulous method of medical treatment. So we want scientific approach combating the COVID. So we're thankful to everybody. Again, we are very much grateful to all the speakers participating in our webinar. Thank you all. And again, I am telling that our organization, Medical Service Center, organizing or raising fund for the IAS affected people in West Bengal, in Odisha. So we are also doing some activity as far as we can for the common people. Thank you, everybody.
Namaskar. Namaskar.